Didn't really, didn't really have any significant medical history that was chronic for her, but she comes in with about 2 to 3 months of cognitive decline. And of note, she was like a very high-powered, like CEO, executive, high-functioning lady. So that was just kind of a very big decline for her. So we can maybe start there.
Thank you so much, Audrey, for joining us. It's so nice to meet you in person, virtually as well. I'm glad you get to hang out with Jack and Robbie every once in a while. I miss doing that personally.
It's been so great.
The PD, yeah, it's the best place. This is a very interesting. So we have a 69-year-old woman who's coming in with like cognitive decline. And one thing that was very helpful with Audrey mentioned is a time frame, right? So for the last couple of months, so when we were thinking about, taking a step back, our altered mental status, we think about like hyperacute, acute, subacute, and more chronic. So so with kind of a like subacute altered mental status, what I usually try to do, just kind of a broad topic, as much history as possible to figure out what this cognitive decline looks like for this patient. And like family a lot of the time can be really, really helpful in providing additional history and those like who live with her. And then my broad approach is like kind of start with our usually altered mental status to think about like metabolic causes, to think about infectious etiology that is like more subacute to chronic in nature, and like structural abnormalities, and then thinking about any medications, side effects, any substances, and then once like we exhaust like kind of that first layer of altered mental status, then taking a step back and be like, okay, is this like a rapidly progressive dementia? Or then doing the altered mental status 2.0, which I'll pass the mic to Jack to delve a little bit further into it.
Awesome. I love it, Charmaine. I think it's such a great modeling of how we can use these schemas in terms of the categories, but alter the different illness scripts that we put underneath each category depending on the tempo of illness. And I completely agree with you, right? There's a number of ways to think about subacute cognitive decline. I think using the MIST that you had mentioned, and then also adding on a couple other diseases that could potentially do it. And the things at least I think about when I think about maybe a cognitive decline that's faster than what we would expect from traditional Alzheimer's dementia, but not the abrupt development that we normally see in settings of acute altered mental status. The disease categories that we can add to our general MIST mnemonic include the things that can cause rapidly progressive dementia syndromes, like Charmaine mentioned, right? About 60% of those cases are going to be prion diseases. And then we can also think about neurodegenerative diseases that may have a sort of abrupt or aggressive presentation, particularly those that might be associated with Parkinson's syndrome, for example, frontotemporal dementia or dementia with Lewy bodies. And then we can rarely be dealing with things that are sort of autoimmune in nature, but happen to hit the CNS. Those could be primary CNS autoimmune diseases, for example, paraneoplastic disease processes, or systemic autoimmune disease processes, for example, diseases like lupus or systemic vasculitis, which can also end up impacting the CNS. And then finally, the mimics that we always don't want to miss are going to be actually psychiatric diseases that may have a cognitive signature to them. For example, depression that may be associated with memory changes, or something like catatonia, for example. And I think the depression one is particularly important in anybody who's over 65 years old, because it's not only underdiagnosed, but can be quite protean in its manifestations. And so I think, just to sort of summarize, we're going to take our general MIST mnemonic, we're going to tweak it based on the tempo, and then we're going to add some of the rapidly progressive dementias, thinking about prion disease, autoimmune diseases, which could be paraneoplastic in nature, or primary CNS or systemic, but then also remembering some of the mimics that we can see, particularly psychiatric diseases in the elderly. All right, Audrey, take us forward here.
Sounds great. Yeah, no, that's amazing. That's exactly the framework that we were using. I think I was just sharing with Amanda a little bit, a little more of the HPI, just to kind of get a sense of the progression. So for her, she is like I mentioned, she was a C-suite level executive. She has a lot of family in California, so a year ago moved here. She had been seen by a PCP just for kind of ongoing weight loss. That seemed like just her main issue at the time, and was in some ways like on goal for that. Earlier this year in January, or actually maybe like more July, her family has noticed she became very forgetful with short-term memory deficits and having a poor appetite. She also, I forgot to mention, had some kind of a strange like allergy, like some like itching and rashes as well, or just felt like this like more like an itchy sensation. So she was seen by a lot of specialists, actually outpatient, including rheumatology, allergy, and so I think those were kind of another thing to note is that she also had during the span of a year about a 30 to 40 pound weight loss, a lot of times because she just felt like she just didn't have a good appetite and didn't want to eat. Yeah. Let me know if you'd like more in that aliquot, or I can kind of.
Why don't you go ahead and take us through like up to the physical exam maybe, and then we can pause again.
Sounds good. In terms of her past medical history, I think there are some things of note. She has a heterozygous Lynch syndrome that was just noted, nothing to do or nothing managed necessarily by that. And then she also has a history of MGUS, where she has a monoclonal gammopathy, but the significance or any sort of manifestations has not really been described for her. She's not taking any medications. In terms of her family history, there is a significant history for like Waldenstrom's macroglobulinemia in the mother. And then I think some other kind of like colon cancer, something is a little bit more common, I think, in another family member that's not immediate. In terms of social history, no alcohol, no drugs, no smoking history for her. And then no known allergies as well. So when I met her, she was a very, very pleasant lady. The vitals were stone cold normal every day. I don't remember any of them, but she was afebrile. Her blood pressure is maybe slightly high in the like 140s, but very consistent. And then a normal heart rate like in the 80s, and satting fine on room air. And then in terms of her exam, I would say a very pleasant lady, maintaining a lot of social graces. So, I think if you weren't paying attention, you didn't have the family history, she would just kind of be actually a well-appearing patient. But I think what was always so striking is just how profoundly scared the family was, just because this is very much from her baseline. I think she was alert and oriented times, maybe 2 on a good day, I think, at the start. But she had a lot of short-term memory deficits and had really a lot of trouble recall. Her attention was very poor. She was unable to spell like world backwards, do the serial sevens. And her insight, I think, was also a little bit limited as well at the start. Otherwise, her heart exam was normal, regular rate and rhythm. Her lungs were clear, no crackles. She had moist mucous membranes, no exudates that we could appreciate. A couple things that were kind of interesting on her skin exam. She did have some pitting nails, which was a new feature for her about 2 to 3 weeks ago. They just kind of looked dry and a little bit like cracked a bit. And then her fingers actually had some, what I thought was like a little bit of skin thickening and like the loss of the skin folds in the distal phalanges. Abdomen exam, sorry, was also normal. I'm just trying to figure out what else. Those are, I think, the skin findings, and then her neuro exam was the most impressive. And then let's see, in terms of her strength exam, sorry, I'm just kind of going all over the place. It was maybe a little bit of proximal weakness, 4 out of 5, but it seemed kind of global. There was no focality to it, and her sensation was intact. Her cerebellar function was also intact.
Amazing. Audrey, just absolutely phenomenal storytelling here, both in terms of the information that you're including, but also the way that this is unfolding. It feels like it's just such an authentic description of how we oftentimes uncover these pieces of information, which is sort of bit by bit, piece by piece, understanding how the story has unfolded, but also the way that the story unfolds right in front of us in terms of we might see a physical exam finding and say, okay, I need to go back and now dig deeper based off of what we potentially found here. I will sort of just pop through and talk a little bit about the past medical history, and then I think Charmaine had to step away, but we'll leave the physical exam for her. Otherwise, I can talk through it if she's pulled away to patient care. But I think there's a couple things that we end up seeing here that I think really can help frame the probabilities of the different underlying diagnoses that we were considering. I will say it's difficult to make progress on the missed element of the DDX that Charmaine outlined without a laboratory analysis and potentially head imaging, but we at least don't necessarily see any focal neurologic deficits at this point, right, beyond just sort of global cerebral dysfunction to really point us in the direction of a space-occupying lesion. So that may make structural a little bit lower down on the list. And again, there's not a prominent systemic inflammatory signature, although many of the subacute infectious meningoencephalitides may not be like abruptly febrile illnesses. And so I think we have to sort of temper taking those out of the picture, but their probabilities may be reduced based off of the time course and then the sort of the findings on neuroexam. Her past medical history and the sort of background presentation of this illness, I think, does allow us to make some progress. The presence of itching and rashes, I think, can help us make progress in maybe a couple ways. One is that most primary CNS diseases, like diseases that are limited to the CNS exclusively, for example, many of the autoimmune diseases that impact the CNS, they will oftentimes be limited to the CNS in their clinical manifestations, right? So for example, things like multiple sclerosis characteristically doesn't come with other systemic manifestations, things like rash, fevers, chills, or night sweats, right? So the presence of the rash points us potentially in the direction of saying, oh, maybe this is a systemic disease process that could be impacting the CNS at this point in time. We then have to ask ourselves, well, what could those systemic disease processes be? And I think in an elderly individual with any sort of subacute illness, right, we're going to focus the vast majority of our cognitive energy on the big three, right? Indolent infections, new diagnosis of autoimmune diseases, as well as potentially underlying malignancy. And the malignancy hypothesis deserves particular attention in this individual who has a known history of Lynch syndrome. Even though she is heterozygous, there is some risk for underlying cancer as a result of the Lynch syndrome, and the known history of monoclonal gammopathy of unknown significance with the family history of Waldenstrom's macroglobulinemia, right? Monoclonal gammopathies of unknown significance can transform into the other plasma cell dyscrasias, for example, smoldering multiple myeloma, or Waldenstrom's, which is basically an IgM gammopathy in the bone and the blood, plus a lymphoplasmacytic lymphoma in the lymphoid tissue. And particularly IgM monoclonal gammopathies can come with cutaneous manifestations. For example, the disease process like Schnitzler syndrome, an incredibly rare IgM gammopathy, can present with an urticarial rash that could be itchy and pruritic like this. And so I think at this point in time, based off of the past medical history, it helps us move our thinking forward and thinking that there's maybe an increasing probability that this is a systemic disease that happens to be taking down the CNS as one of its scenes of the crime, and that systemic disease has an increasing probability of being an underlying malignancy given her age and her risk factors, both in terms of family history and acquired genetic diseases, and hereditary genetic diseases like Lynch syndrome. And then we have to ask, okay, how do we filter that through the findings on the physical exam here? And if we look at what we see on the physical exam, we see sort of poor attention and difficulties with maybe some of our more elevated cognitive functions, for example, like spelling and insight. But then we also have some findings of proximal muscle weakness, right? And so we have to ask ourselves, is this something that's impacting the brain at a space that's going to strategically knock off executive functions and going to strategically knock off motor functions diffusely? Or are we dealing with something that may be impacting the peripheral nervous system in the form of causing a myopathy and the central nervous system in the form of causing cerebral dysfunction? I would say I think the latter hypothesis is more likely based off of the exam findings, because it can be quite difficult to take out motor in a certain muscle group only without any sensory changes, without any other cerebellar findings, but with global cerebral executive dysfunction, right? That would have to be very strategic areas of the brain that get knocked off. But right, there are many diseases that can impact the systemic nervous system and the central nervous system, particularly autoimmune mediated neurologic diseases. So for example, a paraneoplastic syndrome may cause a peripheral nervous system weakness and a central nervous system dysfunction, as well as many systemic diseases that could cause a myopathy may also present with subtle changes in mental status, right? So I think we have to ask ourselves, how can we make progress on the myopathy on exam? I think looking for things like an elevated CK, which may point us in the direction of an inflammatory myopathy, getting a sense on whether this is a fatigable weakness, which may point us into the space of a or of an NMJ disorder, right? And then potentially going down the route of looking for EMGs and things like that to see if it's potentially a neuropathy. I will say neuropathy plus monoclonal gammopathy is a very, very common finding, but a pure motor neuropathy in the setting of a monoclonal gammopathy is a bit of an interesting category to dive into. And some of those are particularly associated with IgM monoclonal gammopathy. So for example, POEM syndrome is something where we may see this, but also other underlying IgM related monoclonal gammopathies that can cause pure motor weakness. And then again, if this is an antibody mediated process, we may also have a way for it to impact the CNS. So that's kind of how I'm putting things together. Again, I think a autoimmune or a antibody mediated process, as well as potentially one that's related to her underlying monoclonal gammopathy, would be, I think, the scent that I would follow most often. But we do need to characterize, both with head imaging and further laboratory testing, both her encephalopathy as well as this myopathy. So Audrey, I will leave it back to you to take us a little bit further.
Amazing. I just love I think this is a really rich case, and I think this is exactly what we were thinking, is like, how do we pursue all the different things, and especially the combinations of possibly weakness and stuff like that. But I'll go through the labs real quick. Her white count was normal. It was maybe in like 7s to 8s. Her hemoglobin, also no anemia. It was like 13, and it was pretty consistent for us. She also had normal platelets. And let's see, I'm just trying to look up labs right now. In terms of her metabolic, her platelets were, I'll just say, in like the 230s, 200s consistently. Her metabolic panel also not super revealing. Her creatinine was at 0.7, AST, ALT in the like low teens, normal bilirubin. Her BUN also in the low teens as well. Her calcium was always like, it was maybe corrected to like 12s, but never got higher than that. And her albumin, I think, was pronouncedly like 2.9, and I think on admission. And I think there was a previous for her that put her around like 3.7. Let's see. In terms of an EKG, it was normal sinus rhythm, and her chest X-ray, I don't remember specifically, but I don't think there was anything super focal. I will say though that there were like in terms of the outpatient workup, that she did, just because of this kind of concern for like malignancy and this concern for the family history, they had gotten a couple readings of a chest CT chest, abdomen, pelvis, and she has I think some like mediastinal lymphadenopathy that appeared, that wasn't super avid, or not that there was no PET, or there was a PET actually previously. So they did a CT chest, abdomen, pelvis. It wasn't super impressive in size. They had done a PET CT, and the avidity was not super impressive, but it was, there still was mediastinal lymphadenopathy. And I think there's just always a big question about the chronicity and the like interval progression about that. I'm happy to give more. We also, while she was admitted inpatient, I think the workup, I think would make sense to do the LP and an MRI just kind of given her new kind of progression. So I can talk about that as well.
Yeah, that sounds great, Audrey.
Interestingly, it was actually a fairly bland LP, like normal protein and glucose, no elevated white count. And then we just kind of sent a lot of things out. So it was just a very large workup, including a paraneoplastic panel, oligoclonal bands, CMV, VZV. I'm just trying to, let's see if I can reference it in my note here. And then also Creutzfeldt, Yaka, we did send out CSF for that as well. Let's see. In terms of other serum or CSF studies, I think we just did a lot of antibodies as well. And this was honestly guided a lot by neuro just because there was so many. So they were thinking of also TPO and antithyroglobulin antibodies as well. And so those were all pending while she was kind of admitted. In terms of serum studies, we had the CK, which was normal. Her UTOX was normal. UA, unremarkable. Normal TSH and free T4. No deficiencies in her B12 or MMA or homocysteine. Normal thiamine. Her PTH was appropriate, and then negative HIV, non-reactive RPR. We had an HMG CoA reductase antibody pending.
Awesome.
Yeah. Oh, and I should say the TPO and thyroglobulin, those are a lot of things were pending, but I'm happy to kind of, depending on how we'd like the story to progress, like share kind of what was revealed.
No, Audrey, I will ask you from a time management perspective, how much data do you feel like is left before the final diagnosis comes out, if there is one in this case?
Yeah. There is, or I guess it's more like a working diagnosis. Okay. I think that there's just a lot of learning in terms of the difference between like getting all these labs and also managing someone while their condition is pending, just because there's a lot of this is a very specialized like send out lab heavy case. And I think a lot of it is actually more management focused, as well as thinking, because I think the diagnostics, we had the same kind of schema every day, but pending these tests, we'll still have to make decisions about it. So I would say there's a couple of things that did pop up positive, and I do see we were running a little bit out of time.
That's all right. I would just maybe what I can do is sort of comment briefly on the ways in which the imaging that we have, or the sort of imaging and the other data that we have, could shift some of the different probabilities. And then I'll turn it back to you to sort of take us home with the case, and then also share these rich management pearls that knowing you, I know you've thought deeply and reflected quite a bit on along the way. So, I think in terms of sort of where to go from here, right, we sort of ask ourselves, where is a place that we can reasonably drop a diagnostic anchor as sort of the center of gravity of the case? And I think it's really hard to actually find some stable ground to do that here, right? The CT chest with some mediastinal lymphadenopathy in the setting of a known monoclonal gammopathy, right? We don't necessarily know if it's an IgM MGUS that she's had in the past, but the lymphadenopathy plus a monoclonal gammopathy does maybe give us some space to circle around, right, in terms of thinking about monoclonal paraproteins that can be associated with various lymphomas. Again, we've mentioned Waldenstrom's as one of the hallmarks there, but many of the different lymphomas can secrete monoclonal or can be associated with monoclonal paraproteinemias. So that seems like a place that we could maybe go down. But then Audrey told us that the PET CT showed that it wasn't really impressive in terms of the FDG uptake of these lymph nodes, which tells us that they're maybe not prominently hyperactive. Certainly indolent lymphomas, for example, like a follicular lymphoma, they can have low FDG avidity just because they're not turning over very quickly. But it's hard to necessarily correlate a slowly progressive disease with a more rapidly progressive cognitive dysfunction, unless there's something that the lymph nodes may be producing unrelated to their activity. We then look and say, okay, well, if we can't necessarily hang our hat on the imaging findings, maybe there's something in the CSF that we'll be able to work with here. And while the very, very benign studies may make us say there's nothing that the CSF is going to reveal thus far, right? There's normal protein, no elevated white blood cell count, and normal glucose. Many of the paraneoplastic associated CNS diseases can have completely bland LPs. And so the absence of an inflammatory CSF here does not meaningfully decrease the probability of a paraneoplastic mediated CNS disease process, which could also have peripheral disease manifestations as well. And so I think as we think about what we've necessarily ruled out at this point, certainly a paraneoplastic encephalitis or a paraneoplastic neurologic syndrome is by no means ruled out now, because again, many of them are sort of will come with non-inflammatory CSF. And so at this point, what we really end up doing is we say, okay, maybe we hang our hat on the lymphadenopathy, in which case a lymphoma leading to a paraproteinemia that's causing a neuropathy is a totally plausible hypothesis, but a bit rare. Again, that would sort of require us to be in the IgM paraproteinemia and probably a lymphoplasmacytic lymphoma DDX. And most of those neuropathies will be sensory in nature, but while they can be pure motor, that would be quite rare. And so we're asking 3 rare pieces of data to come together and to give us the diagnosis, which always feels like a flimsy place for me. But at this point, I think we might explore the possibility of whether one of those lymph nodes is worth sampling, or if we just need to bide our time and be patient. That's about as far as I feel like I could actually take the reasoning on my own here. But I know that I can imagine that you and your intellect and thoughtfulness and brilliance as a clinician, as well as the many conversations that it sounds like unfolded with consultants and specialists, was probably extracted much more reasoning and much more progress than I'm able to come to on my own. So I'll turn it back to you to sort of take us into the end of the case here, and also share with us the things that you learned along the way.
Absolutely. And thanks so much, Jack. I think an incredible job. I think this is definitely one of those cases where there was a lot of consultant input. And I think kind of one of the learning points I would say is like understanding how to manage my own thoughts, but also deferring to like experts and like understanding also how to communicate that to family. There's a lot of discussion, and I think people were just trying to figure out what we could do for our patient while she was admitted, while we were also waiting for a lot of these labs to come and help guide us in another direction. I think that's a really great point for also just saying that the bland LP, it'd be helpful if it was positive, like more obviously inflammatory, but I think that paraneoplastic autoimmune, we're still kind of highest on our differential. While we were kind of discussing, one of the antibodies that did come back positive is actually the TPO and the thyroglobulin, and those were elevated markedly to like the 2000s and I think 200s. I'm not really sure what the marker is, but those were the one signal that we could see. I think our discussion at this point was also getting repeat imaging of the chest and abdomen, pelvis, just to see, especially because there was one that was done maybe 2 months ago, and we wanted to, I think our goal was like, when do we biopsy and how can we do it? That was logistically very challenging because during the admission, her poor PO intake was kind of complicating matters. She just became a little bit more weaker, and I think her mental status was slowly declining. And it felt like every day we could just kind of see the effects of just wasting, like muscle wasting and like malnutrition. So from that perspective, we had a long discussion with family, just trying to understand our certainty, our diagnostic uncertainty about whether or not we feel comfortable. I think the two options are to backtrack is like, should we just give her empiric steroids if we she has a bit of an autoimmune picture, she has some of this like concern for scleroderma, or like, and then also this like elevated antibody that is like TPO and antithyroglobulin, which actually would be consistent with our leading diagnosis, which was steroid responsive encephalopathy associated with autoimmune thyroiditis, or kind of, I think sometimes people I think they're not quite the same, but Hashimoto's encephalopathy is kind of another thing that we were thinking of earlier, versus like, is this some sort of lymphoma that's driving a paraneoplastic syndrome? And I think the biggest decision point that we were trying like coming up against is kind of like how certain like we wouldn't want, in a perfect world, in a perfect situation, we would get this lymph node biopsy. However, it was logistically challenging to do so safely, and it would undergo a surgery. Her albumin is like 2.5 at this point. She's like kind of been more frail. And we were just trying to really figure out like how much do we really feel like these are driving symptoms versus most of our signal autoimmune. So I think that was a big challenge, and kind of getting a lot of input from consultants to kind of help us drive that decision. Ultimately, we decided that we went to radiology, we went down there to try and make them comment very specifically on interval size and growth, especially because now we had 2 data points of imaging. And by and large, everyone was kind of like, it doesn't seem that avid. I think she has chronic lymphadenopathy, but I would be surprised that a lymphoma that looks this aggressive with the CNS symptoms would be not so impressive on the imaging. So for that reason, I think we made the decision to empirically treat with IV methyl solumedrol for 5 days, and then put her on a prednisone taper. And I will say, she was a little bit, like we were concerned I knew that steroids would kind of also confound the picture for her mental status. However, by the end of the course, when she was on oral prednisone, she actually did have an improvement in her in some of her mental status faculties, but she was still very profoundly weak, I think, from the malnutrition.
Wow. Phenomenal case, Audrey. You're getting a lot of love in the chat, and rightfully so. Not only the richness of the case itself, but I just want to applaud you on the way in which you narrated and elaborated on the tension points in the case and how to resolve those tension points going forward. I think it's very easy to talk about it can be very appealing to solely talk about the content of the case, right? But the ways in which we apply uncertainty, manage uncertainty, and sort of weigh probabilities in the setting of a real case is something that's really hard to capture outside of the authentic clinical context. But I think you demonstrated that while it's difficult, it is by no means impossible, because that was a phenomenal representation of the key branch points from a management reasoning process, and also packed full of phenomenal learning underneath as well. So just thank you so much for bringing this to us today. I learned an enormous amount and have a lot to explore in the space of thyroid disease and encephalopathy, which is going to be a fun journey to go on. And yeah, I can't thank you enough for being here and bringing such excellent teaching and just really fantastic storytelling to allow us all to learn from it. So thank you so much, Ree.
Thank you so much. No, it was really fun to do. So appreciate everybody's
Yeah.
and the chat was amazing as always. Just it really could have gone so many ways. And I think that was the hard part, is like, again, she already did have a very extensive workup, and I still feel like there's trying to figure out how to like parse all that out, because we could have gone down so many routes. But I'm glad she was responsive to the steroids, and I think we'll just have to follow up in clinic to see if like she improves in terms of full faculties.
Yeah. Right. Awesome. Well, Audrey, thank you again. I have to pop off, but I'm going to turn it over to Madalena to take us home with the teaching points today. Thank you all again for being here this morning, and we'll see you next time. Have a great day.
Awesome. Well, I will be very brief in the teaching points, but Audrey, I want to thank you again for such a phenomenal case and walking through, as Jack said, really kind of how to balance the uncertainty in cases like this and managing communication with family and all the consultants on board. So I'll briefly summarize some of the teaching that we walked through. So when Audrey gave us the chief concern of cognitive decline, Charmaine kind of walked us through that it's really important to ask, what does this look like for the patient? And in this case, it was a big change from baseline, as she was a highly functioning CEO, I believe. And you can use family often to get a little bit more history if the patient's not able to do so. And when you're thinking about cognitive decline, you can use an approach that we often use for altered mental status, which is thinking of metabolic, infectious, structural, and then toxin, medication, substances. And then you can layer on the time course to kind of filter through some of your differentials. For cognitive decline specifically, we talked through that in addition to the MIST approach, you want to think of some rapidly progressive dementias. 60% of those are generally prion diseases. And then you also want to consider neurodegenerative diseases like frontotemporal dementia and dementia with Lewy bodies. In addition, you want to consider primary CNS autoimmune disorders, which can be paraneoplastic, or more systemic autoimmune disorders like lupus and systemic vasculitis. And of course, especially in older patients presenting with cognitive decline, you always want to consider mimics like psychiatric disease with a cognitive signature such as depression. So when we got more information about the past medical history and review of systems, specifically about itching and rashes, Jack taught us that most primary CNS disorders that are autoimmune are often limited to the CNS and their clinical manifestations. So really that additional information about itching and rashes pointed us in the direction of a systemic disease process that could be impacting the CNS. And then with the additional information of MGUS and the family history of Waldenstrom's, we considered that the patient had risk factors for malignancy because MGUS can transform into malignant and other gammopathies. And then really at the end, we kind of talked about how we can drop a diagnostic anchor. And Jack taught us that the combination of lymphadenopathy and a monoclonal gammopathy, you want to consider lymphomas because some lymphomas can be associated with monoclonal paraproteinemias. And interestingly, paraneoplastic CNS disease can have a normal non-inflammatory LP. So the fact that the LP in this case was unremarkable did not rule out a paraneoplastic CNS disease. All right, well, a lot of fantastic learning in this case. And thank you, Audrey, again, for presenting such a rich learning case, and you all for tuning in today.